Hi, everyone. My name is E. David Crawford. I'm a professor of urology and the Jack A. Vickers Director of Prostate Research at the University of California in San Diego. It was just a few months ago that we reviewed the 25th anniversary of the introduction of the PDE5 inhibitor, sildenafil Viagra, into clinical practice. It became a game changer. It was originally developed for cardiac symptomatology, angina, and later used for pulmonary hypertension. But a lot of other things have occurred with the PDE5 inhibitors over the last few years. In urology, we're very familiar with the use of tadalafil for BPH. And we know that there is some data about females and the use of these drugs and sexual dysfunction. So more recently, there's been some interest in the drug having some effects and cardioprotective effects on men. And joining me are two real experts in the area. My longtime and good friend, Ray Rosen, who now is a full adjunct professor of psychiatry at the University of California, San Diego. For many years, he was chief scientific officer for the New England Research Institute. Also joining me is Dr. Robert A. Kloner, who is an MD and PhD, the chief science officer, chair, and scientific director of cardiovascular research for the Huntington Medical Research Institutes. So let me start out by asking Bob to comment on his interest and Ray's interest in PDE5 inhibitors and possible cardioprotective effects. Bob?
Thank you very much for letting me speak with you guys today. So initially there was concern about cardiovascular safety of PDE5 inhibitors, especially in patients with cardiovascular risk factors or in men who are on antihypertensive agents or nitroglycerin. And we know that the PDE5 inhibitors, phosphodiesterase 5 inhibitors, are in fact vasodilators. So there was concern about using these agents with other vasodilators. Well, it turns out that especially for usual antihypertensive medicines, the PDE5 inhibitors are very safe. There's still a contraindication with nitrates. However, this has been less of a problem since the education of patients not to use nitrates at the same time they're using the PDE5 inhibitors. And so there started to be some evidence that there might be some cardioprotective effects of these drugs. A paper by Rosano and coworkers done several years ago showed that in diabetics that the PDE5 inhibitors could improve the vasodilatation of blood vessels, that is, improve flow-mediated vasodilatation, which is typically reduced in patients with atherosclerosis. And this suggested that there may be a protective effect on the blood vessels. There also appeared several studies in subgroups of men with erectile dysfunction, specifically those with diabetes, suggesting that in men with ED who took PDE5 inhibitors and had diabetes, that there were lower rates of major adverse cardiovascular events compared to men with ED and diabetes who were not taking the PDE5 inhibitors. So with the help of Dr. Rosen and others, we were interested in looking at a larger, broader population of men with erectile dysfunction in the United States to assess whether men who took the PDE5 inhibitors for ED had lower rates of major adverse cardiovascular events compared to men not exposed to the PDE5 inhibitors. And by major adverse cardiovascular events, we're talking about a composite of cardiovascular death, hospitalization for myocardial infarction, coronary revascularization, stroke, heart failure, and unstable angina. And we were also interested in looking at overall mortality rates, that is, mortality from any cause. And so we looked with Health Corps at a large U.S. database from Anthem, and this included over 70,000 men who were in this study. And we looked at those men with ED who were exposed to PDE5 inhibitors. There was about 24,000. And those who were not exposed to PDE5 inhibitors, there was about 49,000. And followed those men for several years. And in that study, we observed an overall reduction of major adverse cardiovascular events of 13% in those who were on PDE5 inhibitors for ED versus those not exposed to those drugs. And this included reductions in coronary vascularization, reductions in heart failure, reductions in unstable angina, all statistically significant, and a 39% lower rate of cardiovascular death. In addition, there was a 25% lower rate of all-cause mortality in those men taking the PDE5 inhibitors for ED versus those not exposed. And there was also what appeared to be a dose-response effect. Those men on the highest quartile of the PDE5 inhibitor drugs had lower MACE events compared to those on the lower doses. In addition, they had lower rates of myocardial infarction and stroke. So this study, although it's retrospective, does suggest a potential cardiovascular protective effect of the PDE5 inhibitors, but there's an association between taking the PDE5 inhibitors and lower MACE rates, but we can't really claim causality here. To do that, one would need to really carry out a prospective, randomized controlled trial.
Yeah, and I would just add two quick comments to Bob's summary. Our findings are remarkably similar to findings that have now come out of half a dozen, at least, research groups in different countries around the world, finding overall similar effects to ours, which gives us more and more confidence in these findings. The other point is that up to this time, none of the research groups have found differences between PDE5 inhibitors. In other words, we believe we're looking at a class effect here. Obviously, tadalafil has a much longer duration of exposure than the shorter PDE5 inhibitors, vardenafil, tadalafil, avanafil. But thus far, the effects appear to be a class effect. And we're hoping, and others, I think, are hoping to see also studies coming out to show whether there are any between drug differences in this effect. If there is indeed a cardioprotective effect, or any of the PDE5 inhibitors to be preferred.
So, we know that erectile dysfunction is sort of a barometer
Yes.
for underlying cardiovascular disease or risk of that. And I find it interesting what you said, Bob, about that the higher doses actually had more protection. In a way, you would expect that people who are on the higher doses probably had more significant disease.
Yes.
It's also not good news for the 5 milligrams of tadalafil that's used for BPH, but who knows? Maybe that'll ferret out to be something. It's that might mean that the effect is more than we think it is if it's in that subset of men that have worse disease and are taking higher doses of the drug.
Yeah, it's a very good observation.
Yes,
that it's especially impressive to see men in that group showing benefit.
Right, and how close are we to seeing this become a sort of a OTC, over-the-counter drug? Some of these PDE5 inhibitors and so forth, because I know a number of them are off patent.
Sure. Do you want me to take that, Bob?
Sure, that's fine.
Yeah. So I think the findings from these retrospective studies, David, support the argument to FDA to make these drugs over the counter, to enable patients to buy these drugs without prescription. However, the risk-benefit assessment of exactly what the implications of that would be are up to our regulatory agency, i.e. FDA. And speaking for myself, and I think for Bob as well, we are very cognizant of the complex set of issues that FDA needs to take into account. And I'll just say, looking backwards, retrospectively, I was part of an advisory panel to Pfizer at the time that Viagra was approved. And we had a series of high-level meetings to anticipate all of the sociological and health outcomes of the approval of that drug. And we missed by a mile, by a huge amount, so much of what happened and how Viagra quickly became part of everything, and everything was changed as a result of the drug. I'm only bringing that up to say the FDA have a weighty decision in whether to make this class of drugs, over the counter. And I think as the benefits accumulate that we've been seeing in these retrospective studies, arguments for changing the status of the drugs, I think, are strengthened. The safety data looks very safe, very impressive. But on the other side, the potential fallout in terms of everything from date rape to sex orgies, or who knows what else, transmission of HIV, the sociological fallout could be quite extreme. And I don't blame the regulatory agency for considering that very carefully and so on. All I'm saying, David, is I think the issue is more relevant than ever, and we will see strong efforts in the next year or two, in the near future, by perhaps several companies to change status on these drugs. I don't know what FDA will eventually decide, and I'm comfortable personally to leave it up to them. It's a difficult decision, ultimately.
There's one thing I might add, and that is that some of the PDE5 inhibitors are approved for over-the-counter in other countries, but in many of those situations, the pharmacist sort of acts as the go-between. So the patient may not have to get a physician's okay, but they would have to go through usually a series of questionnaires that are administered by a pharmacist. So we don't have that situation here in the United States, but I think that I think there's certainly interest in developing ways of administering questionnaires to potential patients who want these PDE5 inhibitors without doing it through necessarily a physician, but some other way of doing it.
Yeah, no, just screening of appropriate versus inappropriate patients is always a big FDA concern, whether for prescription or non-prescription drugs. And that's going to be a very key issue, whether online screening can identify an appropriate patient with a reasonably high level of, reliability. It's an unfolding issue, and you're asking, I think, a very relevant question, David. And personally, I'm looking forward to seeing how it unfolds, and put my trust in the regulatory agency to do the right thing.
Well, this is exciting. I mean, this is very exciting piece of information that you're all sharing with us, and I think that we're certainly not. It doesn't look like we're doing any harm. And there may be some other explanations why this happened, but it seems to be going in the right direction. We know these drugs are effective for treating erectile function.
Right.
We know that as men age, this happens. A lot of men don't go into their doctor to ask to get this, and there have been efforts to have the roving doctor on the internet that prescribes it for you.
Right.
But if this cardiovascular thing pans out, and I think looking at some other databases, do we really have to wait, to have a large randomized trial 5 to 6 years?
Right.
Time will tell. I mean, we've got to look at other intermediate surrogate endpoints here that wouldn't matter. And then we've all used this in urology, the drug, and you worry about the nitroglycerin interaction and things like that, but we don't see that, and there are certain warnings. Look at all the drugs that are over the counter right now.
Right.
The proton pump inhibitors and so many other drugs that have more potent and dangerous than this. And then when you think about the amount of money that is wasted on various nutraceuticals and things like that are supposedly help this that really don't. So time will tell. So Bob, what do you think? What's the next step then? What's going to happen?
Well, we're currently working on some follow-up studies to this study, looking specifically at the long-acting agent, that is tadalafil, based on the fact that there seemed to be a dose response, and we know this is the longest-acting PDE5 inhibitor with a half-life of about 17 and a half hours compared to some of the other agents, which only have a half-life of about 4 hours. So that's one thing. And then also there's, I believe that there is a move to do some randomized controlled prospective studies, at least in Europe. So, we'd love to do one here in the United States if we can get the funding for it.
Yeah, well, I think that this is really going to spark a lot of interest because it's being a cardiologist that you are, that our hearts are a major problem when we get older, and hypertension and all sorts of other things. So great, Ray. Any closing remarks from you?
Just one last thought, David. The interest in women has also sparked recently. Yes. There were early trials, you probably remember, soon after the approval in men, there were early trials to look at whether sildenafil was effective in female sexual dysfunction, FSD, and the results were disappointing. There was not a very robust signal the way we had found in men. So Pfizer and the other major companies pulled back from studies in women. But in the last 8 or 10 years, there have been a real uptick of studies looking not only at women with FSD, but other reproductive issues, endometrial wall thinning, high-risk pregnancies, and other things like that. And we see a real growth in the use of PDE5 inhibitors in women. The question of whether there will turn out to be cardiovascular benefits in women, I think is a very interesting and important question. So I hope that there'll be some resources also committed to prospective studies and retrospective studies, if possible, in women. That's, I think, going to be a really important issue for the future.
And I think Ray makes a very important point. And I think the good news is that the PDE5 inhibitors do work in women for things like pulmonary hypertension.
Right.
So we do know that there is that potential for the PDE5 inhibitors to perhaps have a cardiovascular benefit in women based on the fact that they're commonly used for pulmonary hypertension. And also, they're sometimes used off-label for things like Raynaud's.
Raynaud's.
Interesting. Well, I want to really thank both of you for your time. Very, very interesting discussion. And I think one that's going to have some significant implications in this area. And I congratulate you on digging this up and working on it. So thanks, and hope to get you back soon to discuss more about this.
Great. It's been a pleasure as always.
Thank
Dan.
you very much.